Welcome to another explainer. Today we're unpacking the clinician's ultimate ICU toolkit, sedatives, paralytics, and analgesics. We're going detail by detail, point by point here. The goal? To make this a complete replacement for your textbook. So let's just jump right in.
Here's our game plan for today. First, sedation assessment, specifically looking at the RASS scale. Second, barbiturates and conscious sedation. Third, fast-acting opioids. And finally, number 4, advanced sedatives.
All right, Section 1, Sedation Assessment.
Now, before we even think about pushing powerful drugs, we absolutely have to establish a diagnostic baseline, right? We do this using the Richmond Agitation Sedation Scale, or RASS. Basically, this is a validated scale used for quantitating a patient's level of sedation, and it's especially useful when you're titrating sedatives for agitated patients. If there's one fundamental rule you need to lock into your memory today, it's the numbering system. Positive numbers mean agitation, negative numbers mean sedation. And a 0, that's your perfect, calm baseline.
So how do we actually use it? Well, there's a strict 3-step escalation procedure for a RASS assessment. Step 1 is purely observational. You just watch the patient. If they're alert, restless, or agitated, they're going to score anywhere from a 0 to a +4 based on that observation alone. Now, if they aren't alert, you move to Step 2, which is verbal stimulus. Just speak to them. If they respond to your voice, they score somewhere between a -1 and a -3. But, and this is key, if there is absolutely no response to your voice, you have to move to Step 3. That's physical stimulation, like a sternal rub. A response here, or a total lack of one, lands them at a -4 or a -5.
Let's look a bit closer at the specific behavioral markers for the agitation side of things. At the very top, a +4 is combative. We're talking violent and immediate physical danger to staff. A +3 is very agitated, which usually involves things like pulling at tubes or catheters. Now, a +2 is agitated, meaning frequent non-purposeful movements and actively fighting the ventilator. A +1 is just restless and anxious, but not aggressive. And again, 0 is alert and calm. Distinguishing between a patient who's just fighting the vent at a +2 versus one who's in active danger at a +4 is literally crucial for your safety and theirs.
Flipping over to the sedation side, a -1 is drowsy, meaning they can sustain awakening to your voice. A -2 is light sedation. They briefly awaken to voice. A -3 is moderate sedation. Here, they might move or open their eyes when you speak, but they won't make eye contact. Now, pay attention here because this is the crucial threshold. -1 through -3 only require verbal stimulation. But at -4, deep sedation, they have absolutely 0 response to your voice and will only respond to physical stimulation. And finally, -5 means they are completely unarousable to any stimulus whatsoever.
Okay, moving right along to Section 2, barbiturates and conscious sedation.
The absolute golden rule here. Using these agents literally requires the ability to provide immediate emergency ventilatory support. I mean, we're talking intubation. You never ever push these drugs without a backup plan ready to go. The common agents we use for conscious sedation include midazolam mixed with fentanyl, fentanyl on its own, or pentobarbital. And if you are using pentobarbital, the standard dose you really need to memorize for a typical 70-kilogram adult is 100 milligrams delivered via a slow IV push.
First up in this class is methohexadol, also known by its brand name, Brevitol. This is a barbiturate that's actually more potent and shorter acting than thiopental. It only lasts about 5 to 7 minutes.
For methohexadol dosing, you're going to use a 1g% solution, which yields 10 milligrams per milliliter. Always give a 2 ml test dose first and then administer 5 to 12 mLs via IV push. But here is the critical warning. Methohexadol may actually induce seizures. This is a highly tested side effect, so definitely keep that in your back pocket.
Next, we have thiopental, or pentothal. This one is a short-acting barbiturate that causes unconsciousness incredibly fast, in just 20 to 30 seconds, and the total duration is only about 5 minutes.
Now, thiopental requires some real precision. The initial concentration should be less than or equal to 2.5%, and you give a 50 milligram test dose. You have to respect this drug because the side effects are severe. It causes nasty tissue necrosis if extravasated, and it's a significant myocardial depressant. Plus, and this is a fascinating little quirk, it's actually an anti-analgesic.
Let's shift gears to Section 3, fast-acting opioids. We'll kick this off with fentanyl, or sublimase. This is a highly lipid-soluble narcotic with a staggering potency. To put it in perspective, it's approximately 100 times more potent than morphine.
The standard dose is 25 to 100 micrograms via IV push. Fentanyl is great because it lowers intracranial pressure and doesn't cause any histamine release. But
You have to commit this warning to memory. If you give large doses too rapidly, it can cause severe chest wall rigidity. You definitely don't want to see that.
Next up is an even faster opioid, remifentanil, or Ultiva. This is an ultra-short-acting micro-opioid receptor agonist. Its timeline is just completely compressed. The onset is less than 1 minute, and the offset is just 3 to 10 minutes.
Why is remifentanil so incredibly short-acting? It all comes down to its metabolism. It undergoes non-hepatic hydrolysis by blood and tissue esterases, which basically means there is absolutely zero accumulation in the body. Because of this, you want to avoid bolus doses altogether and just start with a continuous drip of 0.05 micrograms per kilogram per minute. And of course, keep a close eye out for side effects like bradycardia and muscle rigidity.
All right, home stretch. Section 4, Advanced Sedatives.
First in the heavyweight division is propofol, or Diprivan. This is a sedative hypnotic that actually pulls double duty. It's really useful in high doses as a neuroprotectant. But here's a key pharmacological trait you need to know. Its offset time significantly increases after 12 hours of continuous use.
For propofol dosing, you'll start at 5 to 10 micrograms per kilogram per minute and titrate up to a max of 50. It comes supplied as 500 milligrams in a 50 ml fat emulsion. Now, there's a major logistical caveat here. The tubing must be changed every 12 hours. Plus, that lipid carrier provides 1.1 kilocalories per milliliter, which is a detail you really have to factor into the patient's overall nutrition plan.
Okay, everyone, pause for a second because this next point is a critical, can't-miss clinical pearl. If a patient on a propofol drip suddenly develops metabolic acidosis of unknown etiology, it is propofol infusion syndrome, or PRIS, until proven otherwise.
And the PRIS constellation of symptoms, it's incredibly severe. We're talking hyperkalemia, hepatomegaly, lipidemia, metabolic acidosis, myocardial failure, rhabdomyolysis, and renal failure. It's a cascading disaster, which is exactly why you have to stay vigilant.
Our last major drug for today is Precedex, or dexmedetomidine. This is an alpha-2 adrenal receptor agonist that acts directly in the locus ceruleus. Its massive clinical advantage? It provides excellent sedation and analgesia with absolutely no respiratory depression.
Standard dosing involves a 1 microgram per kilogram loading dose, followed by a drip at 0.2 to 1.0 micrograms per kilogram per hour. But be careful. The major side effects to watch for are significant bradycardia and sinus arrest. You absolutely must use caution and avoid giving this to patients with hypovolemia or heart block.
Wow. Okay, we've covered a massive amount of detail today. So I want to leave you with a provocative thought to help tie all of this together. Based on everything in our ICU toolkit, which specific agent would you choose for a patient actively fighting the ventilator at a RASS of +2 versus a patient who is transitioning off sedation at a RASS of -1? Think back to the respiratory depression, offset times, and hemodynamic profiles we just mastered. Work through that scenario in your head. Thanks so much for joining me on this explainer, and keep exploring these incredible tools.